Forward. There we go. So I'm going to be covering a number of areas. First of all, just looking at the complexity of healthcare and what that means for clinical documentation. And I'm going to give you a demonstration of using Dragon Medical to create a note for a patient who comes into hospital with chest pain. Then I'm going to sort of look at some case studies that we've been involved with in the UK, describing what they are, different clinical scenarios, and the impact they've had on the day-to-day workings for clinicians. Then summarize all that by looking at some of the benefits that we've found that speech recognition can bring. I've also got some reading material on a slide for you, and Simon is going to make these slides available so that you can have access to that. And also on the panel on the right, there are some PDFs that he's put there. And we'll have some time at the end for some questions. So let me kick off. This is a great slide from the Ascension Group of hospitals in the US with surgery at the beginning of the 20th century. And you can see, if you can see my pointer up in the top of the screen there, the window being open. And then, of course, surgeons would get lonely in days gone by, and they would operate in the same room together on different patients. But look how far we've come today. Everyone on the call knows this far better than I do. The complexity of healthcare with the machines, the gadgets, the workflow has dynamically changed. And there was a famous and well-renowned physician in the UK called Professor Sir Cyril Chandler, who summed up the complexity of healthcare with this lovely short couple of sentences. Medicine used to be simple, ineffective, and relatively safe. Now it is complex, effective, and potentially dangerous. And that has meant a real need for comprehensive, precise, and detailed clinical documentation. And I thought I'd just show you some figures, which I'm sure you're familiar with, of how busy life is in healthcare. A few examples here from in Australia. On a daily basis, over 380,000 visits to the GP, 79,000 visits to a specialist, and 20,000 visits to the ED department. If you're looking at admissions over a year, that could be something like 10.6 million episodes of care. And for those of you listening in New Zealand, some similar figures here that are just showing how busy healthcare professionals are. And that means lots and lots of clinical documentation. And I've pulled out some figures here, coming back to the Australian side of things, where there are something like 10.6 million discharge summaries per year, 28 million medical specialty visits, which need to have letters or reports. And I won't read them all out, but you can see it equally applies to allied health professionals and to those working in the community. And some similar figures for the New Zealand healthcare market as well. And I suggest, although that seems to be a real challenge, that's actually good news for speech recognition as a tool to try and address this ever-increasing, burgeoning need to accurately document. But what that's meant is, even with electronic patient records coming down the track, a bit of a paper mountain, a bit of a paper conundrum that behests us all. But we undertook a study a couple of years back where we tried to ascertain how much of a clinician's time is spent actually creating a document, whatever that might be. And we found out that around about 10.8 hours each week is spent by a clinician creating, whether it be a discharge summary, an admission note, operation note. A little bit more for doctors compared to nurses, but that works out to be about just short of a third of an average working week is spent creating these clinical documents. We dissected that a little bit more in the UK with 4 NHS hospitals. And the overwhelming sort of message that came out of all of that is that clinicians are really sort of overwhelmed and demotivated by this whole clinical documentation requirement. And one estimate suggests that less than 13% of their day is spent actually with patient contact. I suggested that about a third of that time is creating clinical documents. If you add in the time that's spent looking for clinical documents, repeating documents or stuff that has not been found or been lost, we've sort of found that 50% of a health professional's time can be spent on clinical documentation in one form or another. Quite interestingly, when they're creating documents, 2/3 of that is narrative and 1/3 is structured. And I'll come to the relevance of that in a short while. You'll all be familiar with that electronic health records are becoming the mainstay of trying to look after a patient's well-being, whether in primary care or in the hospital. But a piece of research has suggested that that is adding about 30 to 40 minutes per day of a clinician's time. And that has led to quite a lot of waste. And one estimate suggests that that is around about 3 wasted outpatient clinic appointments per doctor per week, which over a period of a year really does start to build up. So I guess the exam question is, how can technology help overcome this increasing need for more precise and accurate clinical documentation? So I put here in this slide, to speak or not to speak. That is the question. And I'm going to give you an example of speech recognition in a moment, but I think what might be useful to begin with this slide, is just to define what the various options are in the digital world. First of all, I think that you'll be familiar with this in your own environments. There is the digital dictation, where a clinician in an outpatient clinic, for example, will be recording a letter using on a digital tape, and that will go to a secretary either in the hospital or in the UK. We do quite a lot of outsourced digital transcription in places like India, and that letter then comes back, then is checked by the secretary, then signed off by the clinician. The next stage is what we call back-end speech recognition, where that same digital speech file goes through a speech engine, and the secretary is seeing on her or his screen, as that file is going through the speech engine, the text appearing on the screen, and he or she can correct that. And then finally, there's what's called front-end speech recognition, where the clinician themselves is actually speaking into a microphone and seeing that text go on screen where the cursor is in the electronic record or in the Word document or wherever it might be. And I'm going to now give you an example of front-end speech recognition by doing that in a mock EHR that Nuance has. But before I do, let me just give you some sort of headlines about front-end speech recognition. Today, it's really quite accurate. It's about 99% accurate. And one of the big reasons for that is that it has a comprehensive medical dictionary sitting behind it to recognize all the complex clinical terms and all the medicines that a clinician may want to be referring to. Speech is somewhere between 3 to 5 times faster than actually typing a note. And the algorithms for the software these days don't require any training by the user. You may have seen examples of speech recognition in the past where you've got to say a few paragraphs. That's all gone away these days because the algorithms are much smarter and much more sophisticated. One of the key things is having your voice profile. And your voice profile is specific to you, and it follows you around, so that if you're on a device in a clinic, your voice profile will be the same one as if you're in your office somewhere else in the hospital or even at home. And one of the things that we've found popular with clinicians is that the microphone that can be used can be on the smartphone, and that can either be an iOS or an Android type system. So a little bit of background about some of the sort of the features and components of what front-end speech is all about. So what I'd like to do now is I'd like to come out of the slides, and I'd like to go to the electronic health record that Nuance has. This is a mock EHR. Pretend it's similar to the EHR you may have in your organization. I'm actually going to be creating the note in this white space on the right-hand side. And up here in the top right-hand corner is my Nuance, my Dragon bar, which is where is the engine room of all the functionality that I use for speech. And this one here, particularly the important one, is the microphone. So I'm going to create a note of a patient who's come in with chest pain. I'm going to run all the way through it. Then I'm going to stop, and I'm just going to highlight some of the features that I've done with this. So I'm going to take it from here and start recording. Insert admission note. Chest pain stop. Next field. This 68-year-old male presented with a 2-hour history of central chest pain that was sudden in onset and crushing in nature stop. It radiated down his left arm and up into his left jaw stop. It was not associated with exercise or eating and was not relieved with mild analgesia such as ibuprofen stop. He was hot and sweaty, having vomited once before the ambulance arrived stop. The patient was worried he was having a heart attack stop. New paragraph. In the ambulance, he was given aspirin 75 milligrams and GTN 300 micrograms sublingually stop. Next field. Insert patient history. Next field. Insert normal examination. Looks unwell stop. Cold, clammy, and slightly cyanosed stop. Anchor speech focus. The ECG shows ST elevation in leads 2, 3, and AVF, suggestive of an inferior myocardial infarction stop. Release speech focus. Next field. A 68-year-old male with sudden onset of chest pain with ECG changes suggestive of an inferior myocardial infarction stop. Select inferior myocardial infarction. Bold that, underline that, italicize that. New paragraph. Insert my signature. So let me stop there and let me just orientate you to some of the things that I've done. I should just say that I'm sitting in a hotel room and going over their Wi-Fi and heading back to Nuance's servers back in the US. So not the most ideal of connections, hence a little bit of delay in perhaps what you were seeing on screen. But let me just summarize what I've done. I first of all inserted a template for the admission note, which gave me my headings on the sections that I wanted to complete. And where my cursor is now, this is where I put free text in. And you could see that it's really quite accurate. And particularly where I want to say milligrams or micrograms, it represents that pretty well in the free text. Then this next section here, where you can see past medical history, social history, family history, drugs and allergies. This was a command that I'd set up in the background that linked to those relevant sections in the EPR. So instead of me having to type them out, I was able to pull those in because they had already been completed in the electronic health record, thus saving time on that bit of the examination. As I scroll down, I then had another template for a normal examination. And those clinicians on the call will know that a lot of systems will be the same depending on what the presenting complaint is. And it's really important that we include pertinent negatives when we're doing our summary of our examination. And sometimes if we're typing, we may just run out of time or energy, but having a template in there allows that to remain. But I can actually change different parts of that template. And you can see here, I changed the general appearance, looks unwell, cold, clammy. I had something in there as a default to begin with. And I can scroll through and change or leave the same the template as required. Then the investigations, I actually wanted to go to a different part of the record and see what the ECG was. And I did that, but I wanted actually, when I was speaking the report from the ECG, I wanted what I was speaking about to actually go into the investigation sections of my note. So you heard me say that rather strange term, anchor speech focus. And that meant it allowed me to keep that note in this particular section. Then I did some word features of italicizing and bolding. And then I finished off by inserting my signature. Once I've gone through and I've checked the note and I can make any changes if need be, those brackets are still there. I don't want those because that looks a little bit untidy. So I then switch the microphone back on, accept defaults. And you can see that those brackets all go away. So quite quickly, I've created my notes, and I can answer some questions about that at the end. But what I'd like to do now is go back to the slides and ask the question, is this myth or reality? Does it really work? And you can see Loch Ness Monster there in the middle of the slide, just to highlight that question. So I want to do a couple of things. First of all, just talk about a randomized controlled trial that was done in Germany, where 28 clinicians were split into two, and over a period of 120 days, they looked at a number of clinical reports and split them between the two options of either typing or using speech recognition. And the outcome from this randomized controlled trial, that the increased speed of documentation went up by 26%. Really quite significantly, the amount of content, the quality of the documentation went up about 82%. And there was a high amount of user satisfaction at the end of the study. Let me just go through a couple of case studies that we did in the UK. Firstly, in the ED department in a hospital in the northeast of England, where clinicians there were using speech recognition in minor injuries, majors, and resus. And we looked at time, savings, speed, and quality. And you can see in the top of the slide here that the outcome from the clinicians was quite significant. 98% felt that there were time savings doing speech compared to typing. 86% felt there were increased speed factors, such as information being more timely available. And 88% felt that there were quality improvements in the documentation. And we tried to do some estimates on those time savings. And we were looking at about 3.5 minutes per patient. And that does depend on the type of patient that was going through. But we amortized that over a period of a year with the various case mix that was coming through. And speech versus typing, there was a rough saving of around 389 days saved, which is the equivalent of 2 whole-time equivalent clinicians. And we have targets in the UK of getting patients through, and this was going to make a real impact on those targets of having improved throughput through the department. The second study was in outpatients in a large teaching hospital in England. They were using Cerner Millennium, and they were having some issues with their outsourced digital dictation service and a shortage of secretaries. So a whole department, a renal department, migrated over to using speech for the creation of their outpatient letter. And the long and the short of it was that the turnaround time for the letters reduced from 12 to 3 days. Some consultants were getting it out in 1 to 2 days. It depended a little bit on whether they were waiting for blood results to come back. And they were now able to reach an NHS target of getting their GP letters out within 7 days. They reduced their transcription costs by about 77%, and they avoided the need to employ a band 3 secretary, because a lot of that work was now no longer necessary. The outcome from this case study was that this hospital is now going for an enterprise-wide license of 2,500 users to roll out throughout the outpatient department, but to all the other clinical areas on the wards, in theatre, etc. One renal consultant came back with this quote. It had a big impact on his efficiency of getting letters done for any clinic, now able to send them out in 24 hours compared to pre-speech recognition, where it would take him about 2 weeks. Let me just move to an example in the community, a similar sort of scenario with outpatient letters involving 18 physiotherapists this time and 1 podiatrist. Often it's around, revolves around doctors, but we've found a really good, it's equally applicable for nursing staff and for other allied health professionals in the service. I won't go into too much detail about this, but a similar reduction in the turnaround time of letters from weeks down to 2 to 5 days, with increased patient throughput and decreased waiting times. And they reduced a backlog they had. Physiotherapy is often a gatekeeper between referrals from GPs to orthopedic departments, and they would do some vetting of the referrals, and they found that they had more time to get these assessments done, so that the throughput of this screening process was much faster. Then the final example I'd like to give was around the pathology and histopathology, where this particular hospital down in the southwest of England in Devon had a backlog of 600 reports outstanding. They had a shortage of histopathology staff, and they were really needing to do something about it. So they introduced speech recognition into their workflow. Those of you familiar with histopathology, that can be quite complex with cut up, then with the reading by the histopathologist, SNOMED coding and various other things that need to sit behind that. The long and the short of it was that they removed their backlog of 600 reports, and their turnaround time is now exceeding the required national target. They won an NHS Innovation Award to boot, and they're finding that they're having time savings equivalent to 7 man-hours per day. And their lead pathologist sort of ended up quoting saying, "I would not work in a hospital without speech recognition." He wouldn't go back to those old days. So let me conclude by summarizing some of the benefits that I think clinicians and organizations can get out of speech recognition. We've seen the faster turnaround times. That can apply to discharge summaries, outpatient letters, referrals, and particularly meeting national requirements and avoiding any penalties for delays. It boosts clinician productivity and improves the efficiency of their workflow. Less time documenting, that 13% I showed in some study work that we'd done a couple of years back, and being able to spend more time with patients. And clinicians are finding they're going more chance of going home on time. Increased completeness and accuracy, particularly with unstructured narrative. And that applies to all clinicians, but particularly in mental health and particularly with allied health professionals. And clinicians are also finding that they have more timely access to information. It's there when they need it. They're not hampered by that delay of whatever note was waiting to be typed getting into the record, and reducing backlog of letters, referrals, reports, etc. We've also found out that it's making a significant contribution to the added 40 minutes that having an EPR in an organization is making. So that's helping with increased adoption. It's also having an impact on the return of investment for the organization. Anyone listening who is putting business cases together for various technologies, we've certainly found, certainly in the outpatient field with outpatient letters, that it's had a significant impact there, leading to a more efficient use of secretarial time. A lot more time is needed for organizing MDT meetings, and having secretaries having more patient contact with follow-up and that sort of thing has been a real component. The jewel in the crown for me with all of this is improved quality data, because with improved quality data, then the whole analytics bit is vastly improved, helps with clinical decision support and patient safety. And a better quality record should there be the unfortunate situation of any medical legal stuff going on. And finally, putting patient at the center of their care. And I'd like to finish off with a painting done by a 7-year-old girl. Here she is in the consulting room with her clinician. There's her sister who's reading her magazine. That's her mum holding her baby sister. Here is the EPR on the left-hand side, with the clinician busily recording the consultation. And this particular girl drew this painting after what had been a satisfactory consultation from a clinical perspective, and sent it into the clinician. And the clinician was sort of so overwhelmed by this, and this is from the US, where they've had a huge amount of money thrown at the whole EPR side of things. And he wrote, the economic stimulus bill, which was this huge initiative that directed $20 billion to healthcare, largely funding electronic medical records. He said, I wonder how much this technology will really cost, intimating that computers are all very well and good, but what about sacrificing the doctor-patient relationship? And we've certainly found that when clinicians are dictating using speech, the patient feels sort of more involved with that process, and takes away more of the consultation. So let me finish just by, within the slides, I've got some links to some material, which includes some of those case studies I've talked about, and happy to now take any questions that you may have. So Simon, I think you're going to come back and we can have some time for questions.
That's right, Dr. Wallace, I sure am. So we received a few questions during your presentation, so let's get through some of those now. A reminder that if you would like to ask any questions, you can do so now by typing them into the question box in the GoToWebinar control panel. The first question comes from Sally, who asks, you stated that the accuracy is over 99%, but the real issue is understanding the workflow. Can you expand on that a little?
Yeah, that's a great question, Sally. I think the speech side of it, the recognition side of creating a note is now really quite accurate. I think that is an issue, which was an issue in years gone by, has gone away. And I hope when I did my short demonstration of creating a note on a patient with chest pain, that you were able to see that. However, what the key is workflow, because when a clinician creates a document, there is a bit of a workflow sitting behind that. So if I give the example of creating an outpatient letter, depending which electronic record system you might be using, you will bring up the letter template, And you may have some components in that template that you're pulling in, for example, from the electronic record. There may be things about the past medical history or the diagnosis. And it's having a lot of that set up in the background before one goes live using speech recognition. That is quite important. There was one example from another hospital in the UK where they had lots of different templates for an outpatient letter. And they spent a lot of time, each of the clinical specialties, sort of reviewing what their templates were and trying to come up with a much more standardized, rigorous example. And that time that was spent before even considering the speech was time well spent, and how that then fitted into the workflow. So there may be examples that you have in your organizations, but it's workflow is really, really important. I think you can now take the speech as working quite well.
Okay, thank you, Simon. The next question comes from David, who asks, can speech recognition be used in any EMR, and can it be used with other software such as my email or Word documents? Yeah,
that's a great question. So EPRs are very different in their look and feel and what they do, but essentially all the major EMR providers we have worked with, we have partnerships with, and can use speech recognition. One of the terms I haven't used, but it's dictating at the point of the cursor. And if I break that down, when I had the mock EHR up that I did my demonstration in, you could see that I had the cursor in the top left-hand corner. And that, when I started speaking, was where the text was going to go. And so that is a really quite an important component that you can do that in the EPR. As I said, we partner with all the major EPR providers, and being able to speak and see text at the point of cursor is now robust functionality. Others ask about whether I can use it in my email or whether I can use it in a Word document. And the answer to that is yes as well, because we've also found that clinicians, when they start using it for their clinical notes, well, why can't they use it for their email when they're corresponding between each other? Or perhaps they're doing a report in a Word document. And that can also be done as well.
Okay, there's a follow-up question there from Sean, who's asking how much configuration is required by the EMR vendor, and who undertakes the work to set up the clinical document templates?
Yeah, that's another really good question. So I think that one of the key things here within the organization is, by organization, I mean the healthcare organization, is having a clinical lead, a strong clinical lead who gets the vision of where all this is going and the role that speech can play. Because that clinical lead initially is going to be looking at the workflow, and that workflow needs to be dissected. What's the present workflow? And asking the question, what can be done to improve that? And how can speech work as a tool to help that? Now, that also has to include the functionality of the EPR. And so there's then some joint working with your link with your EPR provider. You may have support there from them in, say, your clinical documentation module, in getting that set up to behave as it should do. And then from our side, from the speech side, we have quite a comprehensive sort of training piece where, first of all, we show clinicians how to set them up with their profile, so that they have a profile that, first of all, they're able to take to different parts of the hospital. Then to get them to use speech and get used to this concept of speaking and seeing your text coming out, and then setting up a very small number of templates to begin with. You do not want to be overwhelmed with too many, but just say 2 or 3 templates to get used to the idea of having a layout of a clinical document. And then what we find is that once there's a familiarity with that, then clinicians really get into their stride and build it up further and further. I just finished by saying, going back to the role of clinicians in the hospital, it's an opportunity to have some standards around the documentation that an organization might want to have. So that, for example, a discharge summary, irrespective of a clinical specialty, has a certain number of headings as a sort of a minimum standard. Likewise, an outpatient letter, or maybe a procedure note. So it's a real opportunity for an organization to take a helicopter view of their clinical documentation processes.
Okay, the next one's a quick one from Callum, who's asking, what version of Dragon were you using in the demonstration?
So I was on Dragon Medical Direct, and I would have to go and, this is a demo version, I'd have to go and just see exactly what, if he's after a number, could you just make a note of his details and I'll find out which one that was. But it is the latest version of Dragon Medical.
Yeah, no problems at all, we'll do that. Okay, so we've got a few more questions coming in thick and fast. So Steve has made a comment. We have recently moved from the US where our EHR functioned very well and could have been further improved with voice recognition. However, here in Australia, GPs are typically entering notes while face-to-face with patients. Any thoughts on how efficient or relevant voice recognition is in this context?
Yeah, another good question. I'm a GP by background originally, and in the UK, using electronic records and for data entry has been around for many, many years. Using speech has also become quite prevalent as well. And it's interesting because when you complete a record in a GP, it's often quite short, say compared to a record in secondary care. But what we've found is that once GPs have got used to not typing anymore and actually using speech, that even if it might be a couple of sentences, they'd much rather go into the record, put the cursor in the particular field where they're wanting to record their findings, and actually use it by doing speech. And I wonder whether it's a cultural thing here in Australia. I'm not so familiar with the GP market here, but it may well be a cultural reason that it's not used so much. Whether it's something to do with the actual electronic systems that GPs are using, I just don't have that depth of knowledge, but happy to follow up afterwards if that's something of interest. But just as a bit of feedback, I think GPs have really harnessed this really quite well in the UK.
Okay, the next question sort of talks about general practice as well as pathologists. So a question from Catherine, how long would it take to implement this type of solution in a general practice? And would the answer be any different for histopathologists? And how many hours of clinical lead and trainer time is required?
Yeah, so good question. I think it's probably easier in primary care and general practice because essentially wherever it is in the record of the EPR, whether it's the diagnosis or whether it's whatever it is, you're simply putting the cursor where the where you want that to be recorded, and with whatever microphone device, the GP can then start talking. In pathology, there's the workflow. So this is the W word again. The workflow is a little bit more complex because a department needs to look at everything that happens from when the sample or the specimen arrives in the department. The secretary may be doing some initial registration and notes. It then goes to cut up where a biomedical scientist is then preparing the specimen, and he or she is needing to do some recording of the specimen and what they've done. They have to be hands-free, so they will have a headset on, and often with a foot pedal to then start when they're speaking for the speech to go into the record. And then once the slides have been prepared, they then come round to the histopathologist, who will generally be sitting in his or her room, looking at the slides and then giving their report. From their perspective, they need to put some codes behind it. So what we've done in the pathology space is we've linked up key histopathology terms to SNOMED codes, so that when those words are spoken, they have a codified report going as part of their process. And then, of course, there's national reporting for certain cancers, for cancers in histopathology. So a completely different workflow compared to primary care. But the question's is really well placed, because it is emphasizing the importance of mapping out what that workflow is and spending time doing that, with everyone in the department having ownership of it, so that they feel, one, it's not being thrust on them, but secondly, that they've had input into that process.
Okay, thank you, Dr. Wallace, for those detailed answers. We're just about out of time. We do have a few more questions that have come through, but we might have to take those on notice and follow up later this afternoon, if that's okay. I'll wrap up the session. I trust you have all found the session to be informative. The recording of today's webinar will be available to attendees in the coming days, so keep an eye out for that in your inbox. I encourage you to share this video with any of your colleagues who may not have been able to attend today's webinar. Contact details for Dr. Wallace are now on your screen, and I'll leave the session open for another minute to give you time to write down these details and to download the slide pack and other PDF handouts from the GoToWebinar control panel. While you are doing that, a reminder that if you would like Nuance to call you to discuss any queries you have had about today's presentation, be sure to send us your contact information via the brief survey at the end of this webinar, and I will put them in touch. Thanks again, and goodbye.